Hi, everyone. Good morning, good afternoon, good evening. If you're joining us, you're just coming at the right time. This is the World Hepatitis Testing Week. So if you don't mind, we'll just allow more participants to join, probably in the next 1 minute. We'll have to get everybody on board and we're going to set the ball rolling. But thank you so much for joining the call on the top of the hour. So we'll just give 1 more minute for more people to join, then we kickstart the webinar. Thank you so much for joining. Okay, good morning, good afternoon, good evening. I'm super excited to have finally seen this World Hepatitis Testing Week. It's been a long period of preparations and really putting together the great panels that we have to join us for this great event. My name is Danjuma Adda. I am the past president at the World Hepatitis Alliance. I am also the chair of the African Viral Hepatitis Action Group. Now, why the World Hepatitis Testing? More than 300 million people are living with hepatitis worldwide, but most people don't know they have it. And based on the latest data from WHO, only 13% of people living with hepatitis B have been diagnosed and 36% for hepatitis C. Hepatitis, we know, is a leading cause of liver cancer, but you cannot treat something you haven't diagnosed. And that is why the World Hepatitis Alliance and the World Health Organization put together this great webinar, and we have great speakers. I'm joined with a great person as a co-chair also to speak about hepatitis testing. I'm so excited with this time, with this webinar, and so excited with the great panel members we have, and excited with the audience that have joined as well. Thank you so much for joining. I would call on my co-chair, Diana, to also introduce herself. Diana, over to you.
Thank you, Danjuma. It is very exciting to be on the first day of the first ever World Hepatitis Testing Week. And it's really good to have all you on board. The theme is championing hepatitis testing. And I do believe we have the lifetime champions for hepatitis in this webinar. My name is Faini. I'm at the World Hepatitis Program at the headquarters of WHO here in Geneva. I am responsible for hepatitis country surveillance, program monitoring, and global reporting. And I'll be co-chairing this session together with Danjuma. So welcome all to those who are just joining us. You may have noticed on the slide that this webinar is simultaneously translated to French and Spanish. So do pick your appropriate languages using the icons below as needed. Thank you.
Thank you, Diana, for the beautiful introductory remarks. Now, I said earlier that we all know the data shows very alarming figures, the data shown by the World Health Organization, that only 13% of people with hepatitis B have been diagnosed, and probably only 36% for hepatitis C. This cannot really move the needle towards achieving elimination unless we scale testing. So this webinar is going to be in this format. We're going to have the panel discussion, and we're going to have question and answers. And as my colleague co-chair rightly said, there will be opportunity for translations. Now, the global sector strategy clearly defines the role of civil society and community groups in testing. And that is why it's very critically important that we scale testing. As today, people, if not diagnosed now, will turn out to have liver cancer in the next few years. So we need to do more screening. We need to do more testing to ensure that people are put into care. Because if we do not diagnose, people will definitely come down with liver complications so many years after. So that is why, in fact, as a matter of fact, data now begins to show that liver cancer comes down so very fast. And that's why it's important to scale testing. And the role of civil society and community groups can never be undermined. Community groups and civil society play a significant, in fact, very important role in doing community-based testing, in doing peer navigation, in identifying people, breaking down the barriers of stigmatization, breaking down the structural barriers of people going to facilities even to do testing, but taking testing to the community level. And it's very important that everywhere, either as program managers or donors or funders, to involve community groups, empowered community groups and civil society to be involved in testing. And that's why, as my colleague Diana said, we're super excited that this is the first World Hepatitis Testing Week. And today, 18 starts the week. Our plan, our dream is that the testing should not start 18 and stop 24, but this should trigger the chain of testing. Testing should go on everywhere, every part of the world to identify people, diagnose people, and link people to care. Thank you so much for this, and thanks a lot for all the great people that have joined. And so to help us speak about the role, examples of civil society organizing testing for hepatitis B and C, I will invite the first speaker, Humberto Silva, to introduce himself and give his presentation on the examples of civil society organizing testing for hepatitis B and C. But before then, please, after this presentation, if you have a question, you could drop your question in the Q&A, indicate by raising your hands so that we'll be able to identify you, and then you present your question. So Humberto, over to you, and thank you so much for joining us.
It is a pleasure. Thanks very much indeed, my dear Danjuma, past president for the World Health Alliance. And I'd like also to thank the members of the World Hepatitis Alliance, such as President Rachel Harford, the CEO Kerry James, Alexander Smith, and make an acknowledgement for the important person Charles Gore has been during all of these years for the foundation and for the struggle he has been developing against this problem of hepatitis in the world. I'm the Rotary representative for hepatitis. I'm the chair for Rotary's Action Group for Hepatitis Eradication, trying to give my contribution to it as modest as we can. We're going to be sharing the screen here and showing a PowerPoint presentation. We know that we have only 7 minutes to do it, and we'll try to manage. Our campaign is called Hepatitis Zero, and I'd like to also acknowledge the importance we see in the current campaign that is being launched by the World Hepatitis Alliance, because it resonates so much with my life story. And I use it as an example because most people in the world find themselves, as I did some 15 years ago. I found I had hepatitis as I was heading to the World Cup in South Africa, and decided I should see a doctor and ask for some vaccines for protection. Apart from the vaccines, that doctor, in fact an angel, suggested I should get myself tested for other diseases. And for my surprise, I had hepatitis C. And some days later, I found I also had cirrhosis. But I didn't feel anything. How could it be? But yes, I was in the queue, perhaps a terrible fate, completely oblivious to it. We all know that the first symptom comes too late for hepatitis. And that's why, as we heard, 360 million people in the world are carrying it, but very few are diagnosed. And most of the cirrhosis and liver cancer cases come from hepatitis. So 3,000 to 4,000 people are estimated to lose their lives to hepatitis because of the silence of the disease. So I received that grace from God, as I believe, and I made a vow I would humbly devote to the rest of my life to help the ones who need it, as you here are doing the same way. We started by founding an association in Brazil, opened several clinics, and then we've seen a lot of patients, all for free. And we took the cause to Rotary. Why? Because Rotary is the only civil society organization who has been successful in almost eradicating a disease from the face of Earth, which is polio, right? We are close to doing it, and God willing, we'll get there, as polio is only prevalent in 2 countries, Afghanistan and Pakistan, we've been struggling for 35 years in that direction. So Rotary embraced our cause for hepatitis, and we started testing people. The same that we are going to be doing with this magnificent campaign, which is being launched today by WHO. And we did something almost similar in the past, in 2019, when we launched the Hepatitis Zero Week, which was a fantastic campaign that covered a good part of the world. We tested 1 million people in about 50 countries. And thanks to that, about 7,000 lives were saved. No, all of those people were diagnosed and received the right to know that they had a problem, which is fundamental, as Mr. Danjuma was saying, for someone to solve the problem. Because if someone doesn't know that they have a problem, how on earth they'll ever achieve the solution to it, the cure for it? So the following slides, which I'm going to be showing very quickly, will exemplify the campaign that we did, that we put together with our Rotary almost around the world also, covering 50 countries simultaneously in 1 week. And we did it in so many countries, like in Guinea, Burkina Faso, Bolivia, Nigeria, many parts. In Congo, we had a little problem. They did not want our crew to develop the testing. They almost sent our crew to jail for doing it. Nigeria, Chad, and all of those places. But the campaign which is being launched today, we wish that it not only matches ours, but that it surpasses ours. Because the necessity that we have for people to get tested is tremendous, is fundamental, is pivotal for us to achieve our objectives, which is to lead those to a cure. In Mexico, we had a tremendous, fantastic campaign all over the country as well, in almost all of the states, all over Africa, etc., etc. In Mali was then enormous, Senegal, etc. So I'm showing this to perhaps serve as an inspiration, but not only this, but to say that we, the 1.2 million Rotarians that are around the world, in 200 countries, that we humbly offer our contribution to our dear WHA for this fantastic, this laudable campaign that is being launched today, and that we are brothers and sisters in arms with you, aligned for the same purpose. So that's the result of the campaign that we had then. And may God bless you in this fantastic one that you are launching today. And just a very short video to serve more as an inspiration. So important. I hope there is sound there. Very short. That's it. So thank you very much. Thank you.
Thank you, Umberto.
And let me acknowledge also, Diana, your name and your important participation in this fantastic campaign.
Thank you, Umberto, for those really good remarks and a very heartfelt sharing of your experience. It's very unfortunate, but I do believe the theme for this week in trying to get more people tested is so as to mitigate what you went through. And it's wonderful to see Rotarod is working with its 200 countries in promoting testing. And we do hope with this, in our next report, the numbers of persons who have been diagnosed will increase over time. So moving on to our next presenter, who will also be sharing examples of civil society for testing of hepatitis B and C. I would like to welcome Lucy Matumbu from South Africa. Would you please unmute yourself and introduce yourself to the audience?
Yes, thank you so much, Diana, and thank you to the co-chair, Mr. Danjuma. Good morning, good day, good evening to everyone who has joined in. My name is Lucy Pasika Matumbu. I am working at TB/HIV Care in South Africa. I serve as the chairperson of the NGO sector and also serving as the secretary of the Civil Society Forum in Enhlazeni district in Mpumalanga province. I am the deputy chairperson of the PIWIT sector in Mpumalanga, and also I am a member of the World Hepatitis Alliance. Thank you so much. To start off with my introduction, allow me to say that research has shown that viral hepatitis prevalence is as high as 40% among people who use these drugs due to practices such as needle sharing and a lack of harm reduction services. So because of that, the stigmatization of drug users within healthcare settings further discourages many from seeking testing, support, and treatment. In areas like Nelspruit, Nkomazi, and Bushbuck Ridge, these are the regions that I represent as the deputy chairperson of the PIWIT sector. So these issues are compounded by socio-economic factors, including high unemployment rates, limited access to mental health services, and inadequate education on harm reduction practices. The need for inclusive healthcare services that address the unique needs of PIWIT has become increasingly critical. So what civil society is doing to organize testing for viral hepatitis B and C, it is a great pleasure for me to say that as somebody who's working for TB/HIV Care, I had the privilege of seeing TB/HIV Care begin offering community-based testing for hepatitis B and C to PIWIT in 2023 during our biobehavioral survey. And those tested positive were offered treatment within the BBS program. TB/HIV Care offers testing in our drop-in center, and by using mobile clinics to organize outreach within PIWIT communities. Both clinicians and trained peers conduct hepatitis B and C tests, which are offered alongside testing for HIV, syphilis, and TB. So once someone tests positive for hepatitis B or C, TB/HIV Care links them directly to their organization's program and community health centers. Identifying hotspots allows us to have access to the underdiagnosed and to link them to care. It is true that we need to expand our health educational materials as part of our community-based testing to improve awareness and help reduce stigma associated with hepatitis. Another thing that is very interesting that is coming in our province here in Mpumalanga under the PIWIT sector is that we want to integrate viral hepatitis within the 16th day of activism against AIDS. So the 16th day of activism against AIDS is an annual global campaign that highlights the importance of HIV awareness, education, and action to support vulnerable groups. In Mpumalanga, this campaign represents an opportunity to bring critical health services to PWD communities who are of HIV and AIDS. As the PWD sector within the Civil Society Forum, we want the narratives to change. Gone are those days whereby hepatitis is treated as the unwanted stepchild to HIV and TB. So whenever we advocate for screening and testing for HIV and TB, we must have the same emphasis for viral hepatitis. Hence, we have planned activities to include screening and refer to testing for our PWDs during this coming 16-day of activism against HIV. And we will continue to advocate testing and treatment for our PWD population. However, it is a reality that stigma remains one of the greatest barriers to hepatitis treatment and care among people who use drugs. In Mpumalanga, for instance, people who use drugs are often marginalized, facing discrimination, not only to their drug use, but also to misconceptions around hepatitis. This double stigma contributes to feelings of isolation, depression, and reluctance to seek help, which can worsen health outcomes. Stigma reduction, education, therefore, remains a core component of this event, as it will normalize seeking care, build trust between our clients and healthcare providers, and improves community support for people who are using drugs. In closing, it is true that we need to scale up peer-led models because they are essential to reaching vulnerable groups among people who are using drugs. We need to scale initiatives targeting high-risk groups such as PWD, increase funding for mobile units in rural areas and underserved areas. Another message that I would like to get across is that hepatitis C and B elimination is possible in South Africa with grassroots action. Civil society must continue to lead by innovating, collaborating, and advocating for the underserved. So being part of the WHA is highly appreciated by myself and my peers, and it will go a long way to our advocacy as PWD not to be left behind. Let's work together to ensure no one is left behind in the fight against hepatitis. Hepatitis is no longer the unwanted and treated the same way as HIV and TB. Nothing for us without us. I thank you.
All right, thank you, Lucy. Thank you so much. It's indeed, we're so excited to know that we have a great voice in South Africa, and you're doing a lot in the PWD and key population sector. Humberto, thanks a lot also for your presentation. I remember we met, I think it was in San Francisco, one of those meetings when I first heard your story about the Rotary Initiative. And over the years, it has been, the momentum hasn't really died down, and glad to see that you're still pushing, and we also are pushing from the community angle. So we're opening up for discussions, for questions to the audience. Please, if you have a question, you could raise your hands, or if you will have a perspective you want to share. And please, we have the next few minutes for questions, and we want to also get your perspective on how community groups and civil society could open up the space for testing. Are there people in the audience who have questions? Okay, I'll go straight with Abdul Karim Tawhida. Please introduce yourself, where you're calling from, and then go ahead with your question. Thank you so much.
Thank you very much. It is a pleasure to be part of the World Hepatitis launching session. My name is Tawida Abdulkarim. I'm from Nigeria, and I'm the founder of Health for All Initiative for Community Health. I have 4 years experience in grassroots community, purposely for health promotion. And recently, I became a member of the World Hepatitis Alliance, contributing to the global effort of eliminating viral hepatitis in Nigeria. So my own perspective is, thank you very much for all the speakers. What I would like to add is focusing on hepatitis testing in pregnancy. This is because 80% of viral hepatitis occur during it is being transmitted from mother to child. So when we focus more on hepatitis testing in pregnancy, such that pregnant women who are found to be positive will be given adequate treatment, while the ones that are negative will be referred for vaccination, and also focusing on vaccination among the children, most especially before 24 hours of birth, such that the viral hepatitis will be eliminated significantly as a public health issue. And I will also encourage non-governmental organizations like myself. I'm also working on how to promote the World Hepatitis Testing Week among my
Thank
NGO,
you.
which is the Health for All Initiative
Okay,
for
thank you,
Community Health.
Tahida.
So that's my perspective. Thank you very much.
Thank you so much. Yes, you rightly mentioned testing of pregnant women, and it might interest you to know that there's a WHO recommendation already on that, and policy guidelines are out already. So check either WHO or WHA website. You have all the information on that, and this is great. I would want to ask a question to Humberto before I go back to the audience. Humberto, I love this first statement. You said the first symptom comes too late. That is awesome, and that is a reality we see in most of Africa. And Rotary ended polio, literally. Rotary Club mobilized resources and ended polio. So my question to you, Humberto, is that in what ways would your organization, because the experience we have, for example, from WHA is that you see a lot of commitment at the global level. We have strong collaborations as I speak now with WHO in Geneva, even in regional offices. But if you go to country offices across some countries, you see there's little bit of breakdown in communication. So how would Rotary collaborate with civil society, community groups across all the regions of the world in scaling this testing? Because this is mostly going to be community-based testing. How would you want us to collaborate? How would Rotary collaborate with community groups across the nations to improve testing?
Well, yes, I'll try to be succinct as possible in answering this question, which is very wise, but brings 3 concepts. First, we have to exorcise the idea that a rapid test has got to be absolutely precise, right? That's, the stance that people in the United States have been having against rapid tests, resisting to approve them. They think that if out of 1,000, 5,000 people tested, if we miss one because of an inefficiency of that rapid test, that that test should not be approved. No, it's just a triage. It's just a screening. The positive signs that rapid tests bring, it's fantastic. So you're taking the step in the right direction. That's the first thing. The other thing, answering how we could enhance the participation and the honoring from the part of the governments to actually fulfill what they have promised in that commitment with WHO, is that we do need people to be diagnosed, and they are the ones that have committed to it. They have given WHO like a bond, right? And they have to actually honor their word there. And the thing is, just the last thing, I have had, dear Danjuma, several arguments with people who are against diagnosing if an immediate treatment is not available. The thing is, if you don't know you have a problem, right, there won't be a demand. There won't be knocking on the government's doors, asking for a treatment. So, no bridge is built, no road is made after there is a demand, a necessity, a movement there. So the reason why all of those 360 million people are still neglected is because they are not shown. We haven't shed light to them. We have to put the highlight on them. And the only way we can do it is by testing, bringing them right to the surface. So again, I thank you and I applaud the initiative you're taking in that direction.
Thank you very much, Umberto. That's really encouraging. And I do see this discussion bringing about certain technical recommendations and policies that I think we can address from WHO. And with that, I also like to acknowledge the presence of the WHO Global Hepatitis Program colleagues, including Professor Leshi, Dr. Nicholas, and Dr. Sandy, who I see are online. So do post in your questions online, and we'll be sure to take them on. So I'll go ahead and call the next participants. Kenneth Kabagambe, I hope I'm correctly pronouncing your name. Please go ahead and ask your question.
Thank you so much, Danjuma and the World Hepatitis Alliance for organizing this exciting webinar. As you might all be aware that funding has always been a problem in viral hepatitis. This is a huge problem, especially in Africa, where civil society organizations are taking the lead in trying to provide testing to identify those that are positive. Most of the services that the patients in Africa receive currently in most of the African countries are actually derived by or driven by the civil society organizations. My thoughts about enhancing the testing and link to care. When it comes to times like these, I think we should actually leverage on the existing structures for the well-restricted diseases like HIV, because apparently in Uganda, where I come from, PEPFAR is supporting the testing of pregnant mothers during antenatal care. Unfortunately, the component of medication for those who are mono-infected with hepatitis B and not co-infected with HIV are not catered for, and this leaves the mothers or the pregnant women who are positive for hepatitis B in a dilemma to look for services, and in most cases, this has actually left them in a lot of awkward situation of stigma and discrimination, and leading to mental health. So I am thinking, and also borrowing a leaf from maybe the WHO guidelines of triple elimination. How possible can WHO, together with partners like the World Hepatitis Alliance, make sure that there is a lot of effective advocacy, especially when it comes to the integration of triple elimination initiatives in Africa? Thank you.
Thank you very much, Kenneth, for your question and comments. And yes, we at the WHO has provided guidance related to triple elimination and advocating for testing of both syphilis, hepatitis B, and HIV among women attending antenatal care services. It is our ambition that we reach the testing coverages and the treatment among women has recommended for the eligibility criteria for hepatitis B, so as to ensure that this group who seeks already care do have access to the testing and do have access to the treatment as per eligibility criteria. So yes, we will talk more about this, but I would like to leave that a bit open for Sahara, as she will present on the guidances from hepatitis B and C testing within the WHO guidelines. I would like to call upon the next question from Ibrahim Yerima. Last question before we move to the next presentation. Would you unmute yourself and please keep it short?
Yeah, good afternoon, good evening, good morning all. Mine is, I would like to commend your efforts in eliminating viral hepatitis. For the testing week, we have planned screening in one of our community here in Adamawa, and then we are trying to see how we can mobilize the local community leaders and youth leaders to also participate during the activity. So we had meeting with the village head, and then one of the key questions he asked is how, and then do we have any support to render to people who are positive due to the viral hepatitis? And then we told him for now we don't have any support, but we would like to refer them for we refer them to our hospital that is specialist here in Yola for further testings and all that activity. So thank you, and over.
Thank you, Rima, for that question. I was not hearing correctly, but I think my colleagues will take that up for the discussion later. I would now want to call on Saha. She will touch a bit on the questions that has been raised, but we'll take it up for discussion later. So Saha will speak on the role of testing and elimination and also highlight guidances that we have from WHO on testing approaches. Would you kindly introduce yourself, Saha, and take on with your presentation?
Great, thank you, Diana. Thank you, Danjuma. Hi, everyone. It's an absolute pleasure to be joining you today on this webinar, but more importantly, to be part of this really exciting effort that's been put together by the World Hepatitis Alliance, and for the first time to have a testing wing dedicated to hepatitis, particularly at a time when the hepatitis response has stalled globally, and you're taking action to really get this moving again. So it's an absolute pleasure to be part of that. So my name is Sahar. I'm a consultant working mostly on hepatitis at WHO headquarters. Next slide, please. So my colleagues before have put it so well together just to highlight the impact of viral hepatitis. Viral hepatitis is the only communicable disease for which mortality is increasing globally, and it is the second leading cause of death that's been reported in 2022. Next slide. And again, as Danjuma and my colleagues have highlighted so well, most people with chronic hepatitis B and C remain undiagnosed and untreated, far below our global targets. And in order for us to reach our targets to eliminate viral hepatitis as a public health threat and also save lives and improve the quality of life of people living with hepatitis B or C, we really need to be testing and diagnosing millions and millions of people. Next slide. So at WHO, we have pretty clear guidelines on hepatitis B and C testing. They were first comprehensively put together back in 2017, and they focus on testing recommendations on who to test, so the populations that we should be reaching for testing and diagnosis, where to test populations, how to test different populations. And I'm talking specifically about, doing serology and molecular testing. And also in the last few years, we have developed guidelines to simplify testing and providing recommendations on simplified service delivery strategies and diagnostics, and also evidence-based interventions to enhance testing and uptake of treatment. Next slide. So I'm giving you a bit of a sneak preview into a product that is currently in production, an operational guide that we are putting together that will come out in about 3 weeks' time. We saw a bit of a gap, so we've got all these testing recommendations, and we've got a little bit of gap in wanting to support countries more in planning person-centered hepatitis B and C testing services to really prioritize testing services. And so we want to, with this guide, what we've done is given some guidance around supporting countries in developing a strategic mix of testing approaches that are tailored to each country's unique situation, so based on epidemiology, burden, and resources. And when we talk about testing approaches, what I mean and what we mean is that who do we test and where do we test populations. In that guide, we also provide a 5-step framework for planning person-centered hepatitis B and C testing approaches. And we also emphasize integration. And I like what Kenneth just spoke about just before, talking about integrating testing with other diseases and in primary care, but also looking at differentiated service delivery models that are, again, specific to populations based on these 4 building blocks to do with when, where, who does the testing and what, and specifically for mobilizing and creating demand, testing implementation, and linkage to care. So it's 4 building blocks for mobilizing, for testing implementation, and linkage to care for specific populations. And this is really sort of inspired by HIV. Really, HIV has had this going for quite a number of years now, and it's been quite successful. We also present country case studies, compelling examples from England, Georgia, Morocco, and Uganda, demonstrating how they use key enablers. And again, talking about advocacy here is one thing, and part of trying to enable developing a good strategic mix of testing approaches and good practices, and then implementing them for impact. And finally, we consolidate the WHO testing recommendations for C, B, and D that I sort of just highlighted in the previous slide. And also we provide a consolidation of the quality assured products as well in one guide that countries can access. Next slide. So the premise of that, you need to sort of understand testing services to plan it well, in the sense that, what is the goal of testing? Well, there are 2 main goals for testing. The first is to find cases to reach the largest populations of undiagnosed individuals and link them to treatment and care. The second is prevention, is ensuring that individuals who are negative for hepatitis when they're being tested stay negative, but also identifying new infections early on, particularly with those that have ongoing risk. So this is a core service for PMTCT, antenatal care, and key populations. So based on that, what we want to do is achieve a strategic mix of testing approaches, again, that is person-centered, that is contributing to the larger diagnosis, treatment, and prevention goals. There are different testing requirements that for different populations, for different settings and burden and resources. So again, who do we want to test? Where do we want to test them, and how? Really depends on each unique context. Bearing in mind that diagnosis needs to be made with molecular testing. There's already been some discussion around serology, and then the need to do actually molecular testing for treatment eligibility assessment for hepatitis B and for hepatitis C. We need to do that particularly to confirm active infection. There are a range of healthcare providers, including lay providers, community workers. Self-testing is obviously an important modality now for or testing approach for hepatitis C. We are looking to develop a self-testing hepatitis B recommendation as well. So how do different providers fit into this? Also, testing providers have lots of tasks along mobilizing, testing, and linking to care. Again, how do we integrate that across diseases in primary care to make it efficient and good use of resources, and ensuring that we reach the largest population of undiagnosed individuals? And lastly, testing sites vary widely in size, in the level of capacity, with high throughput, and so on. Next slide. So again, going back to this testing approaches, which is kind of the key highlight of what I'm trying to deliver here as a key message, and for this guide as well, is we've put together basically 3 categories or 3 modules, if you like, in relation to our priority populations. So the first is that number 1 there is general population testing. And we're speaking about testing general populations in settings where the prevalence for hepatitis B or C is higher than 2%. You basically need to test all adults and adolescents in that population when it's so widespread and above 2%, in order to really achieve elimination. Also, we have recommendations around birth cohort testing of age-specific age groups for hepatitis C. And this is particularly relevant in settings where the prevalence in the general population is less than 2%, but it's also applicable in high prevalence settings if you want to basically prioritize based on a phased approach. Now, there are also specific groups that should be routinely tested in all settings, regardless of where they are. And they should be offered care in sort of in all facilities or community-based sort of approaches, if that's the case. So pregnant women should be tested for hepatitis B in all settings. Blood donors should be tested for hepatitis B and C. Also, anybody exhibiting any signs or symptoms of chronic viral hepatitis should be tested as well for hepatitis B and C, and healthcare workers for hepatitis B. And lastly, there we've got a category for focused testing for the most affected populations who are recognized to be at higher risk of hepatitis B and C, and this includes key populations as well. I've got in this blue box for you to see that we do have recommendations now for hepatitis Delta for the first time. It was published this year in our hepatitis B 2024 updated guidelines. So please do look them up for further information. Next slide. I'm just giving an example here again in this guide that we'll be launching in a couple of weeks' time. We do give examples around sort of the building blocks for each of the categories of and each of the populations. We give examples for who to test, where to test, how you mobilize and create demand and link to care. So as an example for general populations, and I'm glad to see Dr. Huma on the call, our esteemed colleague from Pakistan, who will talk about the Pakistan testing approach there in the general population. But really when populations can be quite large as well, you need to think about prioritizing based on geographies potentially, but also based maybe even on birth cohort. And we have a recommendation specifically on hepatitis C in that sense. So you're thinking about, well, what do I have existing currently in our healthcare system? You can offer general population testing in primary healthcare facilities and hospitals. You need to be sort of creative and innovative and integrated in your outpatient department with communicable diseases, but also non-communicable diseases. So thinking hypertension, diabetes, inpatient wards, emergency departments, and there's a very good case study on that in the guide from England. Cancer screening initiatives, outreach, and so on. When you're mobilizing and creating demand, think again about integrating it and how you would do it through mass and social media campaigns, health awareness days, also integrating it with partner and community events. Workshops, faith-based events. When we talk, so that's sort of just some kind of examples for you there. And linkage to care, thinking about how can we actually support pathways of linkage to care. For example, you can have on-site testing, so through decentralization and integration. You can use DBS, dried blood spot testing to make sure that you're reaching populations in remote communities, as an example. Peer workers and community healthcare workers are absolutely instrumental to reach populations and communities where they are. Can't always be doing it centralized. I mean, there's going to be a mix of centralized as well as decentralized and community-based testing. And of course, self-testing can be an additional testing approach for hepatitis C and hopefully hepatitis B in the future. Next. And just my second last slide here, providing some other examples for opportunities for integrating hepatitis testing services. So of course, in facilities, when we're thinking about key populations or antenatal care, so pregnant women, you're thinking about ART clinics, harm reduction size, outreach, thinking about also integrating it with other diseases, as I was explaining to you before. There was a recent systematic review, a study that was done recently to show that if you use integrated triple test for HIV, hepatitis B, and C, for every HIV case, you will identify 5 additional cases of hepatitis B and 3 for hepatitis C. And that was true for all populations except for men who have sex with men. And so this is really key and important to show that there is really a value and a good way to do integration is to do it with HIV. You can integrate rapid testing as well in PrEP clinics. So again, this is mobile clinics that you could be doing it for. And we do have guidance on hepatitis B and C testing in PrEP clinics. And lastly, there is another example as well for integrating health promotion activities across diseases, even integrating self-testing distribution across diseases. Next slide. So I just want to show you a very quick example from Morocco. Morocco has a low hepatitis C prevalence. But what they did is that back in 2019, they did a seroprevalence survey that showed that adults over the age of 40 had a higher prevalence for hepatitis C than the rest of the population. So they identified birth cohort testing is probably a good way to prioritize testing approaches in Morocco. Plus, mix it in with focusing on prioritizing populations at higher risk, including key populations and people living with HIV. Based on that, they developed an investment case. So again, going back to sort of Kenneth's point about advocacy before, that was one way of doing it, developing an investment case for why it is important to integrate and develop a strategy and implement testing approaches for hepatitis sort of C using this approach. And they use that at a ministerial high level. They partnered really strongly with communities, making sure that community-based testing was done with communities and then leadership with communities. And really importantly, they integrated and decentralized into existing services and existing platforms for HIV, and for key populations. So that included using the gene expert machines they already had using for HIV. They purchased the cartridges for hepatitis C and they integrated it. They already had existing human resources for that and they just rolled it out. And then they also did some awareness campaigns, 2 awareness campaigns to galvanize efforts. And it was policy-led. It was in policy to do this. And they did that in 2022, 2023 World Hepatitis Day. And they had really good domestic financing also for testing and treatment. Next slide. And I'd like to conclude, of course, by acknowledging my wonderful colleagues at WHO, in particular, Nicholas Luhmann, who co-led this work. And of course, without him, it wouldn't have happened. And of course, Diana on the call and Faini and all the colleagues there. And I'm looking forward to the discussion. Happy testing week. Thank you.
Thank you so much, Sahar. Beautiful presentation. Great always listening to you with all the passion and the energy to do this. Thanks a lot. So I will just go ahead and call on Dr. Huma Qureshi to introduce herself and then tell us about scaling up testing as a key driver of the national provincial elimination in Pakistan. Pakistan is one of the great examples of hepatitis elimination. Thank you, Huma, for being part of this. Thanks for all the great work you do in the hepatitis space. Over to you. I think you're muted. We still can't hear you. Am I the only one not hearing her?
No, we can't hear either.
Oh.
Aha, perfect. Can hear you now. Thank you.
Okay, I think there was something wrong with my earphone. So anyway, I put it off. So hi, thank you very much, Danjuma, and thank you, Diana, for bringing this very important, the testing week. This is very important because until unless people are tested, they would not know their status and then they would not be treated. So very important, and I'll be sharing with you what we are doing for scaling up of the testing at the national and the provincial level in Pakistan. Next slide. So as you all know that we have the highest prevalence of disease in Pakistan. So this is the Homi Razavi's mathematical calculation that he did for Pakistan for 2021. And at that time, he showed that Pakistan had about almost 10 million viremic people who had viremia and were kind of waiting for treatment. So this was his mathematical model, which he undertook in 2021. Next slide. So responding to this high prevalence of disease and the high viremia in the population, the Prime Minister of Pakistan in July 2024, 29th of July, he launched the Hepatitis C elimination program. And this encompasses the elimination of hepatitis C from Pakistan. We have used a prevalence of 7.5% disease in the population. And this is a totally local funding of Pakistani rupees 68.25 billion, which is about $250 million US. And this cost will be shared with the federal and the provincial government at a ratio of 51 to 49. So slightly more funding is coming from federal, while the provinces will also raise their own funding. So it's a 3 years project starting from July this year and ending to June 2027. The next slide. So we have a population of 253 million, and we are choosing people who are more than 12 years of age. So that makes about 165 million population who needs to be screened, tested, and treated. Because of the cost constraints, we have decided that we will initially screen, test, and treat 50% of the population. So this is about 82.5 million people who would be screened in the first phase. So what the federal government will do is that it will fund the screening for all the population, that is 82.5 million people. And then out of those who are then found to be reactive, then they would undergo screening, the PCR testing. So federal government will support PCR for 30% of the population, which is about 1.7 million people. While the provincial governments will raise their own funds for the rest of the 70% population who will undergo PCR testing by the provincial governments. And similarly, for the treatment, 50% of the treatment would be supported by the federal government, while 50% would be raised by the provincial governments, and that will make about 3.8 million people will be supported for treatment by the federal government, and at the same number by the provincial government. So it's a federal and provincial working together, because we all have to work to eliminate the disease. Next slide. So what we have also calculated that whatever the current rate at which we were testing, screening, and testing and treating the population, we could not achieve the elimination. So we have to increase the screening and testing by 10-folds of the current rate. And as very rightly pointed out, by our colleagues, that most of the population is unaware of the disease and there are no specific signs and symptoms. So we are using the mass awareness campaigns to bring people out, and for this we'll be using the radios, which are commonly still used in our villages, and it's mostly the village population, which is the larger population, which has to come out. Plus we'll be using the mobile messages and the television messages, and we'll also undertake active and passive screening of all the people who come out for testing. And we shall engage the private sector in all these activities. So how we will choose this 50% population is we have decided that we will pick the high prevalence districts in each province, and these high prevalence districts will be addressed first in the first 3 years, and then in the next 3 years the districts which are relatively low prevalence would be addressed. Next slide. So for the active screening, we'll be using a 3-pronged approach in which we have really decentralized the screening and the testing. And from the tertiary sites, because initially we used to have these tertiary sites which were doing the screening and testing. So we have moved it to the primary and the secondary healthcare sites, along with the reflex blood testing for all those who are found positive, and they will undertake the blood testing for PCR. As a parallel campaign, we shall also engage our lady health workers who have their designated houses and areas where they will go door to door and access these populations and undertake their screening and also take their blood for testing. Plus, we shall be using mobile vans also for the difficult to access areas and the populations. Next slide. And for the passive screening, what we plan to do is that in these high prevalence districts, we shall be using the compounds and the schools of the schools, colleges, universities, banks, corporate sector, mosques, madrasas, and we have these Benazir income support program sites where people come to collect their monies. So all these public places will have people, one or two technicians who will undertake the rapid test and will also take blood for whosoever is found positive. So this is how we want to screen people even at their own sites, and we don't want to bring everybody to the healthcare sites because otherwise the healthcare sites would not be able to manage them. Next slide. So we have also mapped these health facilities in Pakistan. So this is the heat map of all the health facilities, both public and private, that we have charted, and we have put them in our map. So except for Balochistan, which you see on the top left side, which has a scattered population and the few, there's not very highly, health facilities are not that much. All the other three provinces have a very, very good scatter of the health facilities. So by and large, we think that using these health facilities and then the door-to-door, we should be able to screen a large population as we have thought that we would do. Next slide. And we shall be using the WHO pre-qualified rapid test and the PCR, so that there's no ambiguity in the testing and the results. Next slide. And we have also mapped our PCR capacity within Pakistan in the provinces and in the regions. So you see on the y-axis we have all these provinces and the regions, while on the x-axis we have these throughputs. So the orange bar is the annual requirement of the PCR that we would need, and if we use these machines at an 8-hourly shift, then we can very easily enhance our screening and testing, through the PCR. So we think that except for one province in Punjab where we might need some more machines, we are quite adequately, start with the workers and also with the machines. And we think that we have the capacity to run the test at whatever rate we have planned to do. Next slide. And we have these hepatitis C medicines, which are generics of sofosbuvir and daclofenacin, and these are produced by nine companies within Pakistan. And they're at a very affordable price of about almost $53 for a 12 weeks treatment. So we shall be using these medicines, which would be made in Pakistan, and these medicines are really very effective. And we have a cure rate of almost about 97% using these medicines. So that's what we plan to do, and I think that's my next slide, please. That's probably my last slide. So thank you very much. So this is how we plan to screen, test, and treat the population. Thank you very much.
Thank you very much, Dr. Huma, for that beautiful presentation. I think we have seen how we work through from understanding where our most burden is, what are the drivers of infection, understanding how to link with private sector to scale up and advocating for testing, but also the importance of a political will to really move people from those who have been diagnosed and provide treatment. Moving forward now to understand better on the commodities that are available for testing and looking at the availability and access of these commodities, I welcome Capucine to present on this, and if you could unmute and introduce yourself to the audience.
Thank you, Diana, and thank you to the World Hepatitis Alliance and to WHO for inviting me to speak today. So this presentation was prepared first for what's called the AMDS network, which is the Access to Medicine and Diagnostic Services Network, which is a technical assistant network led by WHO. That gathers HIV, hepatitis, and syphilis, and they've been looking at the market for HIV diagnostics for many years, but for this time, for the first time, we looked at hepatitis and STIs. So this is the first report of the kind. And I would like to say it's a report, next slide, that looks at LMICs and China. So that's only the scope we're having. We're not going to the entire globe. And it's a partial baseline report. I will explain to you how we proceed and what are the plans for the next steps. So what we really wanted to understand here is the real life market for viral hepatitis diagnostics, because we have good estimates for the need, but we had no idea actually of how much of this need was being met from a market standpoint. And so I'm working on this work for WHO, but with a company called Eureka. And this company specializes in market analysis. So what we did to understand the real market and also to understand what could be the drivers to increase the demand for diagnostics was first to do a technological landscape. to understand all the current diagnostics for hepatitis B, hepatitis C, and triple elimination. We look at RDTs, rapid diagnostics, EIAs, and also molecular. We excluded hepatitis delta because we thought it was a little bit too early and the market is not very big. And after we did that analysis of the technological landscape, we did a baseline market sizing. And I will explain to you a little bit after how we did that market sizing. Next slide. So this is our general approach, which is first looking at procurement analysis and sizing the market. Then we double check the information by interviewing some stakeholders, being companies, non-profits, technical assistance partners. And now we're presenting the insight, and we're also preparing a written report. Next slide. So just taking a little bit step back here, if you're not familiar with market engagement incentives, but that is the different action that can lead to a market growth, market incentives. So a change in guidelines, for instance, or a new national program, or potentially inclusion of hepatitis in a new funders program can be big drivers, but also, for instance, emerging private sector is very important, or the fact that some countries receive some support to address the barriers in the market entry. So many of you here are probably doing some technical assistance on that. And then what we call the first mover advantage, which is if you have a new product, you're likely to have an advantage when you start entering the market. Next slide. So what it takes us, for instance, to do on that basis of analysis is to look at the correlation between these different points. So here we're looking at the correlation between the Global Health Access Strategy, the first one in 2016, and then when the National Elimination Plan started in some selected countries, and then when the Global Fund, Catalytic Fund, it started. And we can really see that the strategy was very important to really get the National Elimination Plan started. And a few years later, the Global Fund started bringing some catalytic funding, probably thanks to the advocacy that was led by this National Elimination Plan. So we can assume that. Next slide. The scope for our research was all the hepatitis tests and the triple elimination RDTs. And we looked at country case studies. So we contacted around 16 countries, and we have data for 12 countries. Half of them is direct data from countries. The other half is we analyzed the custom data, which are very different data sets. Next slide. So this is actually the data we've been working with. So a big chunk is based on global procurers and global donors orders. And we looked at more than 27 million orders between 2015 and 2024, plus 7 of the key countries. And while the data is incomplete, and clearly there's less data available than compared to HIV, we definitely see a strong growth. And in 2023, there were more than 11.2 million tests, and it was half of that the year before and half of that the year before. So we also looked at what's called budget data, which is what donors are thinking to invest in the next years. And you'll see a little that after, but we really think that the expansion is likely to continue, in particularly when it comes to S antigen rapid diagnostics. On top of this data, which is official data from procurers, we looked at customs in 4 different countries. And in these 4 different countries, we had 20 million tests on the private market. And that's what for 2021, because the limitation of this data is that it takes a lot of time to be registered. So we only have data until mid of 2022. And so, as I say, we cross-check everything with stakeholders interview. Next slides. So this is our process. I left it here, but I will share it with the slide. I don't think I need to go in detail. Next slide. And the global can continue. So we have these data sets for hepatitis B, so Global Fund, PEPFAR, UNICEF, domestic funding, and a few other data sets. And there were procurement of all hepatitis B tests except E antigen. We couldn't find anything, at least in this data set. So there might be others elsewhere. Next slide. For hepatitis C, this is the same data sets pretty much. The only thing we didn't really find in the others were Hep C self-test, but we understand it's very new. And there is a small budget volume for the next years in Ukraine, financed by Unitate. So it's starting probably through the market shaping of Unitate. Next slide. You can continue there too. Sorry, I have many title slides. So first thing, for hepatitis B S antigen rapid diagnostics, we can see clearly that Africa is leading the way. And most of the 9.6 million tests in 2023 are from Africa. Next slide. And that's the average price for this rapid diagnostics. And I think it's pretty stable, around 0.85. And next slide. What I find is really interesting is the planned volume by funding source. So we look at 2023 is the biggest year so far, with still a little bit of funding coming on from 2023 for PEPFAR. What's really interesting, it looks like a decrease, but it's not a decrease at all. This is already what is planned. So I'm really expecting that actually we're going to reach above the 12 millions in the future, because this is already, there's going to be a lot more funding and a lot more investment than what is actually already planned until 2026. Next slide. This is the price for hepatitis B PCR, which we know can be really problematic. So it's not a slide that has a lot of clear information, but it tells you an average, and it goes between $46 to $15 pretty much per cartridge. Next slide. And the volumes that we see in global procurement are pretty low for when it comes to hepatitis B PCR, which is a bit worrying, but we're hoping that it means that there is an integration happening at the national level, and maybe it's just not in our data set. And in other data sets that look more at primary care or at different programs, we could find these molecular platforms. Next slide. For Hep C, you can continue. For Hep C, also makes a lot of sense that you can see Egypt, the Middle East and North Africa, it's basically Egypt is leading the way, and also that Eastern Europe and Central Asia and Asia Pacific as where you can see the most hepatitis C test volumes. Next slide. And then with budget volumes, they're not as impressive as for hepatitis B, but they have grown for more than half between 23 and 24. I don't know if that's going to be as sustained. We can see it's a little bit lower for the next few years, so there might need some advocacy there. Next slide. That's the average price for hepatitis C RDTs. It's also relatively stable on the rise to 105, so a little bit more expensive than hepatitis B. Next slide. Which tells you how much you should be paying if you're buying some, not more than that. Cambodia, next slide. I just have a few country examples, so you can move to the next slide. 3 countries that are really going to invest in hepatitis screening. Cambodia, you can look, they have a strong plan. Next slide. Ethiopia also has a lot of investments planned, and it's a lot supported by the Global Fund. Next slide. And South Africa, as we were discussing, the South African colleagues seems to be really picking up. So we're really glad to see that. And this is national investment. Next slide. So that's the trade data. And I just want to show Pakistan, next slide, because it's really one of the biggest countries. And bear in mind, it's only 2021. So I'm really happy to hear UMA and to know this is going to really grow. So there is 13 million hepatitis tests in 2021. And next slide, what I think is really interesting is that a lot of these tests are not pre-qualified by WHO. So they haven't been cleared by WHO if you want, but they're the same price. So if you anticipate buying a product that is not pre-qualified as being cheaper, it's not true. It's actually the same price. So it's probably worth it to invest in pre-qualified products. Next slide. Next slide again. Next slide again. I kept a few slides I want to share with you for later. In the product landscaping, I think the most important thing we're looking at today is the emergence of the hepatitis C self-tests. One is now pre-qualified by WHO. And next slide. The most interesting, I think, for the future is the development of triple elimination multiplexers for mother-to-child transmission with HIV, syphilis, and hepatitis B. There's a few reasons for that. Of course, there's convenience for the health worker, but also I think it's really an interesting strategy for financing, because I think global donors that are interested in dual HIV syphilis will be even more interested to add S antigen to their package. Just it will increase their impact. So I think it's a really good idea to move in that direction. Next slide. Next slide. And that's just the end, the key messages. So I think we really need better data systems on procurement, and we're working with WHO to try to improve that. We see that some policy change can lead the way in increasing screening. We are very glad to see both a growth for hepatitis C LDTs, S antigen, quite a high growth, and also triple elimination seems really to be adopted. In some countries, there's as much S antigen test being ordered as syphilis tests, which is showing really a triple elimination strategy for vertical transmission. But of course, manufacturers all told us that we need to be really careful not to multiply the regulatory barriers for them to be able to be competitive and for access to be guaranteed. Next slide. I just want to say thank you to the partners. A lot of people have participated to this report, and to WHO in particular. It's a WHO report, so you can direct question at WHO or at myself. And an important point, personal point, is that I know many of us last year worked in integration of hepatitis testing into the Global Fund requests. And it has really been successful, and I think we should continue, because the Global Fund is investing 10 times more than it used to do in hepatitis B and C screening in the next few years. And the above allocation period is about to start, so I think we should be still advocating, working with our colleagues working in HIV to try to create more health for everybody. Thank you.
Thank you very much, Capucine, for that overview and understanding where we are, where countries are doing, and perhaps what to look forward to in the near future in terms of funding for hepatitis testing activities in countries. And I do like the article that you have made to improve and encourage countries to put up in their proposal to the Global Fund on including hepatitis testing within the general population and in the specified populations. So we will now open up the floor for discussions, and really looking at what has been presented in the last few minutes on understanding the testing priorities, understanding the political commitments from government in trying to scaling up testing and then putting those who have been diagnosed into treatment, but also understanding what is out there in terms of commodities for testing, so that respective government as well as civil societies can look and procure this appropriately. Please raise your hands, and I'd like to call on those who will raise their hands. But as we are waiting for persons to raise their hands for questioning, I would like to call upon our colleagues from the Global Hepatitis Program, Dr. Nicholas Lugman, who is online, just to provide a few remarks regarding hepatitis testing and what his take is on this week as we start today in championing for hepatitis testing. Nicholas?
Hi, Diana. Hi, Danjuma and Huma and all the others. Can you hear me?
Very well.
Yes.
Great. Great. That's fantastic. In fact, I'm calling in from Vietnam, where we're just finishing a program review. It's already quite late in the evening. Congratulations for starting this important week. Just as an example from the field almost, I just would say, you know, first of all, Vietnam is one of the really high burden countries for hepatitis B and C globally and in the region. And as we were working the last week through our program review, I cannot tell you how often we have discussed how central, you know, testing and linkage to care is to make the response progress. What happens and what we heard from many of you today is it's a quite silent disease. Many people are not aware of their disease, and then people are tested very often quite late, and so there's quite little active population-based testing. And if we really want to change the trajectory is really what we have to do, is that there's more community testing, more facility-based testing, and not just waiting for the people to come in when they're really sick already. So that is one of our key lessons here from the field. And the two things that are related to that is that for that, we need to raise awareness about the importance of hepatitis and the relation to liver cancer and liver disease. And the other one is that there needs to be strong linkage to care, because we don't only want to test people, we want to treat them and cure them for Hep C and suppress the viral load for hepatitis B. Thanks. This is really something absolutely essential that's coming up all the time. And we hope that we can contribute as well to that with our small contribution and the policy operational guide that Sahar presented, that we will launch very soon in relation to this testing week. Thanks.
Thank you very much, Nicholas, for those remarks, and again for stressing the importance of strategic testing in those areas that may be missed in the population and within specified populations, and advocating for linkage to care for those who are diagnosed to be positive. Are there a few questions online?
Yes. Yeah, so Diana, yes, I wanted to maybe reflect the questions someone asked, and I would want maybe any of the WHO colleagues could respond on testing of age groups. Please, there are questions about now with the normative guidelines that looks at adolescents and young people testing. So what would be the recommendations on age groups testing? So maybe any of the WHO colleagues could speak to that.
Sahar, do you want to take that?
Yes, sure. Thanks for the question. So again, it depends on, first of all, the epidemiology, the burden in that setting. So in a population where the general population prevalence is above 2%, the current recommendation is that you would test all adults and adolescents at this point in time. We don't have a recommendation for children, but we don't have it for as a general population testing. So we have it for adults and adolescents at this point in time. However, if you're looking at less than 2% or just for people at higher risk of infections, so key populations, obviously children to positive, say, mothers or household members, they should all be tested, of course. And so we don't have, it's true, there's a bit of a gap, I think, in relation to children, but we have it specifically for those who are positive. So children from a positive mother or family members, they should be tested for hepatitis B or C, really, but particularly B, as we're talking about that. So I'm not sure if that answers your question a little bit. I don't know if others want to chime in, including Faini or Nicholas. But I think it's something that we need to probably actually clarify a bit better in relation to really stratifying sort of that testing recommendations for children and adolescents, not just for children from positive mothers or household members, but actually, you know, a more sort of nuanced testing. So I hope that sort of kind of tells you what the recommendation is at the moment, but I'm happy for others to add. Over.
Thank you very much, Sahar. We do have a hand up in the audience. If you would like to go ahead and ask your question. Maïga, I hope I'm saying your name correctly.
Oui, bonjour. Vous m'entendez?
Oui.
Je voudrais poser une question. Je suis médecin, je suis membre du comité de pilotage au niveau du Mali, qui regroupe plusieurs associations qui luttent contre les hépatites virales. Donc actuellement, je travaille dans un hôpital et nous savons qu'au Mali, nous avons une prévalence très élevée pour les hépatites virales B. Je voudrais poser ma question à Monsieur Umberto pour son projet du Rotary. Est-ce qu'il peut nous parler rapidement de son projet hépatite 0 du Rotary? C'est ma première question. La deuxième question, qu'est-ce que le Rotary a fait jusque-là dans le cadre de la lutte contre les hépatites virales et quelles sont les perspectives pour l'avenir? Parce que nous savons que le Rotary a beaucoup travaillé dans le cadre de la polio. Est-ce que le Rotary va aussi mettre toute sa compétence et son énergie pour nous aider à lutter contre les hépatites virales? Donc, c'est ça mes 2 questions. Merci.
Oui, merci à toi. Et nous connaissons le travail que tu as fait dans ton pays. C'était très, très important pour l'hépatite 0 à son component de la lutte contre les virus de l'hépatite là-bas. Nous avons mobilisé beaucoup de gens. Je pense que nous avons déjà parlé extensivement sur les projets et que nous voulions pouvoir servir d'inspiration pour les projets qui est lancé aujourd'hui pour la World Hepatitis Alliance. Si je pourrais dire quelque chose en plus sur le programme de l'hépatite 0, c'est que nous avons trouvé que la meilleure manière de prendre l'attention des publics en général, aussi comme des autorités de moyens de médias, c'était en faisant des dépistages parce qu'elle pose une très efficiente action utile pour le public. Parce que les médias n'est toujours intéressés dans des sujets comme ceux-là de l'hépatite. Mais quand on organisons un dépistage, nous attractons l'intérêt des moyens de médias. C'est là pourquoi je pense que cette campagne du WHA sera une campagne très, très bien succédée. Merci pour ta question. J'espère que mon français était entendible.
Okay, thank you, Humberto. I think that was a good response, and we are just 3 minutes to the. Yes. I'm afraid we need to wrap up now. So please, would the host maybe, okay. Could the host maybe mute him because we're running over time, almost just 3 minutes to time? Humberto, is it still addressed to you? My French is so horrible. I failed French class in school, so my French is so horrible.
You're doing fine. You are a great leader for our cause, and we are all very proud of your leadership and honored to be together in this cause, Mike. So,
all right. Thank you so much. Thank you so much for this. Merci beaucoup. Thank you so much. That's the best I could speak in French. Merci. Thank you so much. I think it's been a great 1 hour, 30 minutes discussion. Please, can I ask that you mute your microphone, please? We're really running over time.
Danjuma, I'm not sure if you're getting some audio interference feedback. The line seems clear to me.
It's clear to me too, Danjuma.
I think you may be getting some audio feedback, Danjuma. We're not hearing anything at the moment, so.
Oh, okay. All right, merci beaucoup, thank you. So it's been a great 1 hour, 30-minute discussion. And I think for me, as a person diagnosed with hepatitis B, I would say that this has been a great discussion, and it is really an opportunity for us to scale testing. There's no better time than to do now to scale testing and test and test and test. I was diagnosed with hepatitis B way back 2004, and I started treatment quite early. So we cannot stay back if we do not diagnose more people. We need to test. We need to ensure we link people to care. The gap between testing and linkage to care is so huge for both hepatitis B, hepatitis C. And I'm happy, we are glad with the presentation of Capucine about commodities. It's really discouraging sometimes, Capucine, that the WHO PQ test kits are beyond the affordable cost that most communities would afford to buy. So we need to have the commodities out there. We need to have more testing. And one other thing about hepatitis testing is that, unlike in HIV, hepatitis community groups are not given opportunities in most national programs to do community-based testing. Most community groups are considered quacks and not empowered with knowledge, with training, with resources. So hepatitis community groups need to be empowered. Affected populations need to have resources to do testing, resources to do peer navigation, resources to link people to care. Without this, we cannot move the needle towards elimination of hepatitis. And we, as the World Hepatitis Alliance, we want to thank the World Health Organization, want to thank Rotary, want to thank all the panel speakers. Umberto, we look forward to partnerships with you and Rotary. We look forward to working together with you and all the Rotary groups all over the world to increase testing and diagnosis. And let me round up by saying this. There are people out there that if we do not test today, they'll come down with liver cancer in the next few years. Let us go out there and save lives. Let us go out there and test more people. Diagnose as many people as possible. Link them to care. I see so many people coming to our facility here with end-stage liver cirrhosis and end-stage HCC when they diagnose and there's nothing medical science can do. We need to stop this. Many more innocent people are dying. This needs to end. So from the World Hepatitis Alliance and of course, our colleagues from the World Health Organization and all the speakers, all the panelists, thank you so much all for joining. Please go out there and test. Test and test and test. Let us do more testing and link people to care. Au revoir. Thank you all and bye-bye from us. And do have a nice day. Thank you and bye-bye.